All right, so for core competencies, we will start with who should use these, who should use core competencies. We are going to be talking about individuals, organizations, researchers, and educators. So for the purpose of this content, I will be covering all of the above because some of us have dual roles. Some of us want to be able to incorporate research into the materials we use and know what kind of research we should be using, not necessarily developing, but research that we should vet before bringing it into. So the core competencies for human trafficking response, the material we're using today came from the National Human Trafficking Training and Technical Assistance Center in correspondence with multiple different agencies, one of them being the Department of Children and Families and Heal Trafficking, who is where my certification is from on this material. So there are 6 competencies, then there's the universal competency. So the universal competency is the use of a trauma and survivor informed, culturally responsive approach. So as you can see throughout the different competencies we'll be talking about for the remainder of this morning, is there's going to be broken down into different sections. There'll be like a lead topic, and then we'll talk about how that applies in all these different areas. So for starters, we will be talking about the universal competency, which is the use of a trauma and survivor informed, culturally responsive approach. So we'll be talking about trauma informed care, lived experience, expertise, and leadership, and then culturally responsiveness. So there are 6 guiding principles to having trauma informed approaches. So the CDC, the Center for Disease Control's Office of Public Health Preparedness and Response, in collaboration with the acronyms are really hard for me. SAMHSA's National Center for Trauma Informed Care developed this training opportunity for professionals about how to stay trauma informed in public health emergencies. So right now, during the COVID-19 pandemic that we are still all living in, some of the core things or the 6 principles that guide a trauma informed approach are safety, trustworthiness, and transparency, peer support, collaborative mutuality, empowering voices and choice. That one is so important. And then cultural, historical, and gender issues. So in adopting a trauma-informed approach is not accomplished through like a checklist or a particular technique. It requires a variety of things to be at play here. So constant attention, giving awareness, caring about what's going on, having sensitivity, and possibly a cultural change at an organizational level, right? This can't all be approached by just the individual. Kind of like what is the whole point of core competencies is it doesn't attack just one person or target one person. It focuses on the need of all the different places in which this can be applied. So an ongoing organizational assessment and improvement is necessary when creating like that entire systematic change. So trauma-informed care. So that involves recognizing any person could have experienced trauma that can be impacting their decisions, their actions, what they need in healthcare, what their behaviors are like. Oh, does somebody have a question? Okay. And with this recognition, providers are able to practice a trauma-informed approach that assesses stress and trauma, again, without that goal of disclosure. I will be saying that a lot today. And also avoiding re-traumatization, right? We don't want people to be re-traumatized or to be scared or going to a trauma response when they're seeking healthcare services. It also focuses on educating and empowering patients and building resiliency. These will be factors that we talk a lot more later on today. This is broken down into those different levels: the individual, organization or institution, research, and education. So when we're looking at Trauma-informed care. When we look at the organization or the institution as a whole, we are wanting to stay up to date on trainings, assess the capacity for maintaining a trauma-informed approach. So again, it doesn't land on just one person or one group of people to implement trauma-informed care. It relies on everybody in the institution to be adapting to the changes or policies in play. And especially in times like now when we are at heightened stress, short staff, people being out due to illness or exposure or things like that. We want to keep that in mind. Integrating trauma-informed and biased reduction methods into intakes or screening protocols. What does that look like at your organization? Does it follow a trauma-informed lens? Have clearly communicated informed consent. This again will be talked about throughout a lot of these core competencies today. What is your informed consent policy? How do you explain it to your patients? Everybody kind of has their own specific spiel on what confidentiality looks like, what informed consent is, what statutes you might have to abide by, right? All of those things. How are you telling your patients about that? Who are you telling about that if there's more than one patient in the room? If possible, establishing an agency-wide commitment to trauma-informed care. How does that work? What does that look like? What does your agency currently have? Can it be adopted? Create a supportive environment for staff that promotes employee wellness. This is so important. Making sure that your staff has a safe place to go when they are experiencing, vicarious trauma, or they are being activated, or they're dealing with just a really difficult patient and they need a place to just go and unwind for a minute. How are you promoting employee wellness? Are you throwing a pizza party, or are you offering resources that connects them to therapy, connects them to support groups, connects them to spaces where there is a place to unwind and relax, or just seek out a moment of peace during the workday? What does that look like for you? Taking those proactive approaches to emotional and psychological welfare for those frontline workers to prevent burnout, which is huge right now. I'm sure everybody here can attest to that. Tackles that vicarious trauma piece that we talked about earlier and provides those opportunities for self-care both on and off the clock. Individual trust and rapport building. This is so important. You have to have trust. You have to have rapport in order to have trauma-informed care. And that falls on both you and your patient and you and your colleagues. I mean, if you don't have the ability to lean on your coworkers, how are you supposed to take care of yourself when you're on the job? I can attest to that when I have a wonderful group of coworkers right now that I trust and I can lean on, and I know that they're there for me whenever I need it. In other jobs, that hasn't always been true, and that led to burnout. That led to me being easily angered and frustrated and having a much shorter fuse than I would have if I had the spaces to feel supported by my colleagues. Understanding the wide variations in trafficking experiences and those overlapping victimizations. So a lot of what we talked about earlier, it's not a one size fits all. There's oftentimes a lot more needs that have to be met other than just the trafficking experience that they're going through or have gone through. Understanding racial, cultural, historical, and other inequalities that exacerbate trauma. What else is going on in their life? What else have they experienced? Do they identify as LGBTQ? Do they identify as Black or Brown or Native American or Hispanic or any of those things? Do they identify as having historical trauma? Has their family, are they second generation immigrants? What does that look like for them? What else are they having to deal with on top of their current experience or what they're currently presenting as at your agency? Steer clear from problematic language. Again, use self-identified language, use education materials or pamphlets or brochures, whatever that looks like, that talks in a way that is trauma-informed and empowerment-based. Avoid shame-based materials or ones that discourage people from accessing a comprehensive network of services and just focus on the one resource, right? Be aware of secondary exposure, that vicarious trauma, and recognize signs of burnout. When you start to recognize those signs of burnout, there are things you can do to fix that, right? So you don't completely burn out and are no longer able to do the job you were doing. That means taking a vacation, which I know is so hard right now. If it means just taking that day off, calling in sick, leaning on your support networks, knowing what those signs are for you, because every person is different, and then doing what you need to take care of yourself in that way. And again, seeking help for yourself too. Does your employer have an EAP program? What are the benefits of that? If they don't have an EAP program, what does your insurance cover? If your insurance doesn't cover that, what resources are in your community that are free or affordable that allow you to get access to your own care as well? Research, right? Evaluate effectiveness of trauma-informed approaches in healthcare. What does that look like? How effective does a trauma-informed approach compare to one that is not necessarily trauma-informed, or a trauma-informed approach that is outdated, right? What do those look like when you're looking at the two of them? Conduct multidisciplinary research that focuses on health disparities among a variety of populations, and use this research to develop evidence-based approaches for those with lived experience of trafficking or other forms of trauma, right? What I talked about earlier, you want your information to come from people with real lived experience, not people that are talking about being an expert. They very well might be, but if they're just using their words and not the words of survivors, what does that mean? How much weight does that carry? And that multidisciplinary research piece, right? It's not just your organization that is dealing with this. It's a wide variety of them. You cannot fix or address every single problem somebody may have. What referrals are you making? Are you on your county's MDT or your city's MDT? Are you connected with the different resources in your area that offer comprehensive services or refer to other services that they're not able to address the needs of themselves? Identify those barriers to services and disclosures of trauma when seeking medical care. So including findings in an evidence-based approach to provide trauma-informed screenings of new and current patients. Work with anti-trafficking professionals to evaluate prevention and early intervention strategies to mediate vicarious and secondary trauma in healthcare professionals. Y'all already see a ton of stuff. You hear stories, you see people on their worst day, you see people on their best day, you see people that are experiencing some type of disparity or trauma or experience that they need help with, right? What are you doing to care for yourself? And how are you working on prevention in addition to response in that way? And education. Provide and or seek out education, which is evidence-based, trauma-informed, survivor-informed, and has best practices in approaching and assessing risk of trafficking. So like today, attending this training, but what else are you doing, right? Are you incorporating the materials that you're learning into your practice? Are you bringing that to your colleagues and sharing that information, or keeping it to yourself, right? What does that look like for you? Providing ongoing supervision to healthcare professionals if you have the capacity to or able to, and students, and evaluating competency on trauma-informed practices. When we talk about competency, we talk about, or it's often associated with expertise or with an understanding of the purpose for it, right? So really looking at that and looking at your understanding of it and asking yourself, am I competent in this? Or, the language of that is kind of shifting in some places, cultural humility. What are you unsure of? What are you unaware of? What do I need to educate myself more on, right? Understand the impacts, signs, and symptoms of vicarious and secondary trauma, and know what methods are able to be implemented to prevent and address that impact on providers. So not only is it good to understand what that looks like, do you understand what that looks like for you, for your staff, for your colleagues, for your friends and family, right? Anybody that you interact with, what does understanding those symptoms look like compared to what does responding to those symptoms look like? B, lived experience and expertise and leadership. So when we look at this, when we look at individual lived experience, expertise, and leadership, patients are the experts of their own experience. They lived it, they're living with it, they're dealing with it, they know what's going on. Their input should be included in every decision-making process, right? And when we're talking about minors, that gets tricky, right? Because they can't always be the one that consents to certain things, certain procedures, certain medications, right? Their parents are. Are their parents the protective parent? The person they're making the decision, somebody that cares about what their child wants or what the child wants. What does that look like? I know there's so many limitations into what can and cannot be done in those situations, but also listening to the input of the child when offering options to things. Recognizing that trafficking victim survivors have expertise beyond their trafficking experience, right? They don't just know about what they went through, they know about their entire life, their medical history, what works and doesn't work. And of course, there are those times where there's hesitations if there is, previous substance use, if there is other ongoing conditions that they may have, mental health concerns, right? But again, they are the expert of their own life, and taking in what they have to say is important. It doesn't have to be the complete deciding factor for people with those extenuating circumstances, but keeping that in mind when having those conversations and offering options. Survivor experiences can best inform healthcare provider practices. What is your agency's policy on grievances or complaints or feedback? Are you getting feedback forms? We'll talk about that in one of these next ones, but keeping that in mind. Mirroring language used by the patient. So if they call themselves a victim, if they call themselves a sexual assault survivor, if they identify as being trafficked, if they say like, oh, my relationship is fine, he's my partner, she's my wife, she's my significant other, my spouse, mirror that language to them. Don't identify it as something else. If I call my husband my partner and you call him my husband back, that's giving a different label than what I'm self-identifying as, right? Also, using, gosh, wow, words are all of a sudden really hard to use. Using language that is non-gendering, right? Assuming partner, assuming significant other before identifying them as being heterosexual, right? If somebody just says, oh, what are you married? What's your husband's name? What if I'm married to a woman? What if I'm not married? What if I'm just engaged, right? What does that look like? And why are you identifying for me, right? Being mindful of that when interacting with folks. Organizational and institutional. So developing a strategy or protocol to include survivor voices when implementing change, prioritizing experts with lived experience. So do you have a place for patients to come and talk about their experience that helps when looking at ways to change the way practices are done in your place of work? We have a survivor board, I think it's quarterly or semi-annually, where we invite our participants to come and discuss the care that they received, what could be better, what was good, what would they like to see changed, and we apply that every time we get that feedback, so that way we can continue to grow and provide better services to those seeking them out in our community. Utilizing patient feedback from those with lived experience of trafficking or exploitation to inform medical and behavioral health policies and programs. What do the feedback forms look like for you? I know I get a mailed one every single time I see my primary doctor. Do I send it back? Nope, not really. I don't take the time to do that. What is a different way to get me to do that feedback form? How else am I going to be more encouraged to fill that out the next time I see my primary doctor? Sometimes if it's a really wonderful experience, I'll send it back because they deserve to know when something good happens. But not all the time, not all the time. When we look at research, so conduct multidisciplinary research within your community in partnerships with experts with lived experiences. So again, that multidisciplinary piece, not limiting it to just the work that you do, but inviting those from other spaces to provide feedback as well. And within your community, right? Oftentimes when we hear about human trafficking, we think of the big cities. We think of Milwaukee, we think of Madison, we think of the Twin Cities, right? We think of those big populated places and we don't think about the maybe more rural places that we are. For example, I'm located in Chippewa Falls right now. I can't tell you some research that was done in Chippewa Falls on response to human trafficking that I haven't done myself, right? And then engaging with experts and those with lived experience to design delivery of services within your institution. What does your screening process look like? What does the questions you ask patients look like? Every time you go to the doctor, are you weighing and getting them their height and weight? What is the need for that? What is that doing to the people that come to your clinic? When you ask them when the last time they or how frequently they drink, and it's like, oh, sometimes, frequently, not at all, heavily. What does that mean? How are you asking those questions? And what are their nonverbal cues saying when you're doing that, right? And taking those responses and applying it to research to maybe change some of those policies at your organizational or institutional level. And lastly, education, engaging with those who have lived experience and or expertise in the development and delivery of trainings and other educational materials on trafficking. So making sure you're including those voices of survivors when you are doing this research. Where is that put into your educational material? Are you giving credit to those survivors where it's due? What does that look like for you? And C, culturally responsiveness. So the National Institute of Health defines cultural humility as a lifelong process of self-reflection and self-critique, whereby the individual not only learns about others' cultures, but one starts with an examination of him or her own belief and cultural identities. So again, this falls into those categories of individual, organizational, and institutional, research, and education. So when we look at cultural responsiveness at the individual level, we need to be aware of potential cultural factors that influence your professional and patient or client interactions, and know the steps to take and overcome those barriers with sensitivity and respect, right? We are not going to be culturally competent at all times. We will more often than not be culturally humble because we do not know everything about every culture. And we need to understand where we have our blinders on, where are we not informed, what information don't we have, and the information that you do have, be aware of those factors, right? I might not be able to make eye contact with somebody of a certain ethnicity or religious background because in their culture that might mean disrespect. To me, that means that they're not paying attention. What does that look like for me as the provider, and how am I addressing that? Be aware of the diverse cultures represented in your area and how their cultures may impact their medical and behavioral health beliefs and practices, right? Not pushing people to make decisions that are outside of their religious or cultural beliefs. What does that demographic makeup look like in your area so you're more aware of individuals in your area that might come in with those beliefs or those the diverse backgrounds that they may have, right? Demonstrate cultural humility, adaptability, and responsiveness to patients from different cultures, nationalities, gender identities, orientations, races, ethnic backgrounds, religious groups, all of those different things, right? Always be culturally humble. It's okay to say, I'm not super familiar with your religion. Can you tell me a bit more so I can make sure that I am giving you the best care possible? If a doctor said that to me, I would like them 10 times better than if they pretended to know what I'm talking about, right? And if it just goes to show, I don't have to be the expert on everything. I'm the expert on what I know, and what I know is what I'm the expert on, right? If I don't know something, I'm not going to pretend I do because that could cause harm, right? That could put barriers in place for them to get the best services provided, right? Bring in a consult if you need to. Okay, so be aware of encounter aspects of privilege, explicit and implicit bias, what we talked about earlier, and discrimination that may negatively impact patient-client interactions, healthcare practices, and decisions related to those referrals and resources in your community. So again, where your bias is coming into place. Are they internal? Are they external? Are they somewhere in between? You recognize your privilege. I'm a white woman. That gives me some privileges. I also have some things that are barriers in place for me, and I can recognize where those are and what those look like, what those look like, and what I can do to address those myself, right? Cultural. Implement a cultural responsiveness and implicit bias training for programs for all staff in all areas, and have supplemental resources and refresher trainings as a result of that. So when we, I'm sorry, I put cultural up there. I meant to put organizational and institutional. So sorry about that. So yeah, having those trainings, being more aware, educating yourself at an institutional level, because you can only change your individual, but that can only do so much. If you're practicing cultural humility and the next person that takes over care is not, what is that shift looking like for that patient, and how are they being impacted in that way? Engage professional trauma-informed interpreters whenever a language barrier is present. Avoid those familial members, especially their children, or accompany adults as a translator. Like I had mentioned earlier, the medical drama show I was watching yesterday, they used a familial interpreter. It was this individual's son. He didn't want his father to know about the diagnosis he received, and so he told him something else because they didn't use a professional trauma-informed interpreter. If you're unable to have an interpreter in person, there are other options. Use an interpreter line. Find, if at any case, another doctor or nurse that might be able to do some interpreting until you get somebody that is a licensed professional. Because if something is not interpreted correctly, there are remedies that can be had in those cases, right? Especially when law enforcement is present. You don't ever want to use a law enforcement officer to be that interpreter, because they might not communicate what you're saying efficiently or correctly, because they might have a different motive. Not that that motive is bad by any means, but it might be different than what you as a medical or healthcare provider is, okay? Provide trafficking resources and awareness materials that reflect all types of trafficking in all languages. And I understand all languages might be a stress. Maybe the languages that are most common in your community, and have access to interpreting services if the people present that doesn't have those resources in the language that they primarily use. Implement a zero tolerance policy or approach to bias or discrimination towards patients, and establish a method in which staff, patients, and families can report those concerns. What is the grievance policy? Does it go to patient experience? Does it go to your supervisor? Is it a form they have to fill out that is lengthy and uses a lot of big words that are hard to understand, right? What does that look like for filing those reports or grievances? And then develop and implement hiring plans at all levels that reflect diversity and representation. Do your postings encourage people of color or people with, dual language encouraged to apply? Is the salary posted? What does that look like? What are the educational requirements for these? Are they able to be adopted to allow people with learned or lived experience to equate to educational experience? What does that comparison look like, and how are you screening in or screening out those applications? Right, and looking at research, so expanding evidence base for culturally specific aspects of trafficking, including risk, resiliency, and relevant cultural beliefs and practices about victimization, health manifestations, and appropriate treatments, right? What does it look like to have an evidence-based approach to all aspects of trafficking, to risk, to resiliency, to cultural beliefs, right? What does that look like in research, and how can it be implemented in your area? Expand the opportunities for culturally specific treatment and traditional healing modalities, right? If somebody prefers a more holistic approach, what does that look like for you as a provider when offering resources? Are you only providing options for Western medicine? Are you only providing options with the newest technology or the newest procedures that might be offered, or are you providing alternatives that are less invasive or meet their needs better than what you might think meets their needs, right? What you think meets their needs compared to what they think meets their needs. The patient has their own lived experience. They might not always know what the best outcome would be for them, but that's not your decision to make, right? It is their decision as their own person with their own autonomy. Conduct research that explores systematic biases in the health sector that impact individuals who have experienced trafficking, and develop and test strategies to overcome those biases. So what biases do you hold? What understanding do you have of human trafficking, and how is that impacting your ability to serve them, right? Somebody might be presenting as with heightened sexuality. They are more sexually explicit. They might be dressed in a more revealing way. How are you treating them compared to somebody that might have come in a turtleneck and long pants, right? Are those biases coming into play in the healthcare that they're providing, comparing and contrasting to what does that research show, and how can it be implemented in changes in policy or practice in your place of work? And education, adequate training and refresher trainings materials for healthcare providers to increase their capacity to care for individuals who have experienced trafficking while using that cultural and linguistic responsiveness. So what does it look like when you are responding to individuals of different cultures and different language barriers? And how can you continue to train providers on that as we learn more, as we understand more, as we experience more? Okay, so that was the universal competency of a trauma-informed approach. So that one kind of like oversees all of the other competencies and provides a basis of understanding, and we move into these next ones. So core competency 1, so understanding the nature and I can never say this word, epidemiology of trafficking, which will be broken into 2 categories: the nature and scope of trafficking, and the trafficking and social determinants of health. We will be talking more about the social determinants of health later on as well, where I will kind of go in and define that a bit more broadly. But for now, kind of focusing on these 2 topics. So the nature and scope of trafficking. Human trafficking is a crime that affects individuals of all ages, races, nationalities, genders, and sexual orientations, and it can occur in nearly any situation of labor, illicit or illicit. So we also look at the social ecological model, which kind of is broken down into 4 different categories: that individual, relationship, community, and societal. So the individual, meaning their socioeconomic status, demographics, identification with specific populations and cultures, their citizenship status, what that looks like, relationship, their family, their partners, their friends, their neighbors, what does that look like? Community, what resources, what are the societal norms in your area? The labor wages, what is your minimum wage compared to maybe the next big city over's minimum wage? Schools, look at the school breakdown. What school gets more funding? What school has better, overall GPAs or access to resources or college admissions or people that enter the workforce right away? What are those looking like in different parts of your community? And then societal, laws and policies, systems, knowledge of labor and sex trafficking and those misconceptions of it, and then health and economic equality. That kind of makes up the entire social ecological model that'll come into play throughout the rest of the conversation on competency 1. So the nature and scope of human trafficking, A. Individual, recognizing the variety of exploitive activities that constitute both labor and sex trafficking. We looked at that image earlier that had the list of like 20 different businesses or jobs that people might have that could be experiencing sex or labor trafficking. Be able to define them, the disparity and differentiate the severe forms of sex trafficking from commercial sex, right? Where are we confusing that? What is the big factor there? It's consent, folks. And the severe forms of labor trafficking from labor exploitation. There is a difference between trafficking and exploitation. It's not huge, but there is one. And human trafficking from human smuggling, talked about that earlier, and recognizing the possible intersections. So I want to back up and just say the difference between trafficking and exploitation. Like I said, it's not huge. Trafficking usually involves somebody that is in charge, somebody with that power and control over another person. Exploitation is they're being exploited. It's not one person that's controlling them. It's a variety of people, or it's nobody, right? They might have to be exploiting themselves to meet their needs in exchange for a good service or fee, right? So while the experiences of exploitation fall under the definition of trafficking, they are different from what we know as trafficking. And then understanding and applying definitions of trafficking to accurately identify situations that may be trafficking or may be exploitation, right? We need to know what that looks like to be able to define it. But again, not every single person with an experience of trafficking or exploitation defines it as such. Your role as a healthcare professional is to be able to recognize what those signs of somebody being unsafe are, to be able to refer them to the right places or intervene appropriately. Organizational and institutional. Providing role-specific training to all staff and defining and recognizing exploitive activities that constitute labor and sex trafficking. So somebody that is in charge, let's say a phlebotomist, might have a different role in identifying and recognizing trafficking than a primary care physician, right? Different relationship to the patient. Somebody is there for a couple minutes to take their blood. Somebody else sees them every year for their annual exam, and anytime something else happens that they go to the doctor for, right? They have a better ability to establish rapport with somebody than somebody in a position that might only be in and out for a couple minutes. Research, invest equitability in research that further informs the understanding and scope of both labor and sex trafficking, that clearly articulates limitations, right? You're going to have limitations. You're not able to do everything. What are those limitations and where can we address them, and what can we do to change limitations that don't necessarily need to be in place? Education. Integrate information on the definitions, nature, and scope of trafficking into curriculum at all academic levels and in all healthcare fields. So being able to understand what human trafficking is, what the different nature of human trafficking is, what it looks like in different places, and understanding the scope of it across all boards. And using appropriate evidence-based terms and concepts in educational materials. So again, avoiding language like modern day slave or a white slave, or talking about human trafficking in the modern day sense of people being kidnapped and taken and sold over the internet or kept in these brothels, right? We need to understand and use appropriate evidence-based research that addresses all forms of trafficking, not just the ones that we want to talk about. So trafficking and the social determinants of health. So the social determinants of health are conditions in the places where people live, work, learn, play, and it affects a wide variety of health and quality of life risks and outcomes. So at the individual level, we need to identify economic, cultural, and social contexts that contribute to the risk of trafficking, including adverse childhood experiences, so ACEs like we talked about earlier. Economic pressures. I mean, right now, the cost of living, I feel like, has skyrocketed since last year. I mean, I'm noticing it. I'm sure a lot of y'all are too. How does that might be playing a role? What are people more at risk to do when they face those economic insecurities? Racial inequities, right? What are we doing to target the differences in services provided or access to services for people of different races? Homelessness, hunger, right? Migration, marginalization, mental illness. That one is so huge. I know so many of the people I work with also have co-occurring mental health concerns. And I know that my limitations as a victim service provider, my focus, or I shouldn't say my focus, my expertise is not on mental health. At least not all mental health, right? I need to know my limitations so I know where I can best refer folks in the future. And then cognitive and developmental disabilities, how does that play a role, and how are we able to include those when looking at service provision for those experiencing human trafficking? Apply knowledge of the social determinants of health approach in cases of human trafficking. Where are the intersections? Is it affecting the individual? Is it affecting the community? Is it affecting the relationships that they have? Is it affecting society, right? What do those look like, and how can we address that as the individual providing that care? Organization and institution. So integrating a social determinants of health approach into all staff trainings and policy. Do we know what that is? How does that look like in our care? Where can we add that to places that might not already be? Including information on relationships between ACEs, again, a huge factor in risk for youth being exploited and adults being exploited after having experienced ACEs as a child. Oh my goodness, this word is always a challenge to me. Socioeconomic challenges, what that looks like for them, and then risk and protective factors of trafficking. How can we take all that information and bring it to an organization and institutional level? Research, so design and evaluate research that identifies evidence between the social determinants of health, ACEs, socioeconomic changes, migration, risk, and protective factors, and resiliency. How do all of those pieces play a role in providing services to survivors of trafficking through a social determinants of health framework? And lastly, education, integrating social determinants of health approach into curriculum, all levels, focusing on that evidence-based approach piece. And then illustrate the intersectionality for the social determinants of health and individuals at risk of trafficking through case studies. I think this is really important. So for those of you that are on MDTs, on CCRs, that have maybe internal groups that allow you to present case studies and work through difficult situations, how are you incorporating the social determinants of health into that when we're looking at risk, when we're looking at disclosure? What does that look like for you and your agency? And is that something that can be brought in if it's not currently happening? All right, and competency 2, how are folks feeling? Do we need to take a quick break before we continue, or are we good to keep chugging along until lunch? Okay, I'm going to take that as we're good to keep going. So competency 2, so we have 5 more competencies left, but I planned to break to somewhere in between. I don't remember exactly which place I have our lunch break in, but it's just about 11. I plan to break around noon. So we have about another hour left. So maybe we can just take 5 minutes for folks to get a glass of water, use the bathroom, then we'll jump back in. All right. Everybody can see my slides all right? Okay, So competency 2, evaluating and identifying the risk of trafficking. So this is broken into 2 categories. The indicators of trafficking and evidence-based assessment of risk. So in the workbook that most of y'all got, there are a couple different, I think like screening tools under this specific competency that I won't go over in too much detail today. But they are screening tools that were provided by Heal Trafficking and the NGH Institute that are ones that can be used and that are pretty evidence-based tools to be used in healthcare. Okay, so identifying the risk or the indicators of trafficking. So once again, disclosure, not the goal. Definitive evidence of trafficking is not necessary to identify risks of exploitation. Trafficking experiences vary and they are often misidentified due to other forms of violence being present as well, and the nature of the relationship with their trafficker, especially in cases of familial trafficking. So when we look at the indicators of trafficking, it again broken down into the 4 categories. So we have individual, which is identifying the existence of red flags of trafficking in patients and use those indicators to determine if your patient is exhibiting any. So what signs might they be showing? Is there another person in the room? Is that person talking most of the time? Are they not able to explain where their pain is coming from or where their injury occurred because who is identifying as being their mother or their partner is speaking for them, right? What does that look like when you ask about how their pain or how their injury happened and they say that they got it at work because there was no safety protocol in place and they didn't show up with any insurance and they seemed to be unkept, right? Maybe they haven't showered in a while and they have some red flags that might not say that trafficking has happened, but something else unhealthy might be going on, something else to pay attention to. You develop rapport and build trust and facilitate those conversations with patients when examining those indicators. So again, your primary care provider might be able to develop that rapport and build that trust easier or more frequently than somebody that you see not as often, somebody that maybe your emergency room doctor that was there for just the end of their shift and saw you for maybe an hour, right? The next doctor that comes in might be able to provide more of that rapport building process. So passing on those conversations and that information to the next person providing care can be really beneficial. Organization and institution, what that looks like, staying up to date again on those trainings for all staff on those indicators of trafficking. We are learning more about trafficking every single day. These conversations change, the definition changes, right? Human trafficking used to be defined as super similar to human smuggling, but they weren't always separated because we learn more on what this looks like. And by those changes, we are constantly having to adapt and change as well. Have information available to patients on trafficking and exploitation. Almost every clinic has a wall of brochures or in the room has one of those like little things that has a bunch of different options for resources in there. Maybe have one of those be on exploitation or trafficking or even domestic abuse and sexual assault, right? Because we know that they so often overlap and co-occur. Research, so develop and or use evidence-based lists of indicators and screening tools for all populations affected by trafficking. So not just focusing on sex trafficking, not just focusing on labor trafficking, not just on the ones that seem to be the ones that catch our attention more, but on all the different kinds, right? And frequently evaluating the validity and the reliability of screening tools. Again, we learn more every day. So how does that change with materials that we have? Are you using a screening tool from 2001 in 2022? Or are you using a screening tool from maybe 2017, which again, still 5 years old, but significantly newer than one from 2001? When was the last time your hospital screening tools have been updated or your organization screening tool has been updated? Making sure to pay attention to those. So you can ask those questions and maybe find one that's better fitting for today's times. And education, implementing an evidence-based curriculum when you train, recruit, and hire new staff. Are you even talking about human trafficking when hiring new folks at your organization? Using, again, evidence-based curriculum in academic institutions when educating students on human trafficking. So are the different technical schools and universities and online training programs, are they talking about human trafficking? Are you providing training or education to students or outreaching in the community? And are you talking about human trafficking? What does that look like? And using simulations to practice interactiveness when suspecting someone may be actively or have previously been trafficked. You don't want the first time you have this conversation to be with somebody that is experiencing this. What if you say something wrong? You probably will. We all do, right? But what if you can do something ahead of time to prevent that from happening? I know role play is sometimes really uncomfortable and embarrassing, and you want to impress the person you're role playing with, but it is so beneficial. And it is judgment free, right? You're learning, you're practicing. That's exactly what it's there for. Even going through what we did earlier, those myths and facts, right? Seeing what your knowledge is, seeing what you know, where are your assumptions at? Being able to look at the knowledge you carry and the knowledge that you don't, right? So identifying risk. Here's one of the screening tools that is in your pamphlet or in your workbook. So this is the adult screening tool for labor trafficking or sex trafficking. They may be any of those things, right? What is their age, gender, race, nationality? They may be LGBTQ or have any immigration status, right? It acknowledges that it could be any person. Are they experiencing force, fraud, or coercion? Circle one, right? Is the person, is there somebody there speaking for them? Do they not know what day, month, or year it is? Are they constantly moving around in their seat, right? Let's see, they don't know where they live. They don't know what city they're in. They're not allowed to come and go at free will. They are afraid to answer questions. They're working insane hours and are hungry. They might have an odd living or workspace, like they're living at work. That's a red flag, right? You should not be living at work. They owe a debt to their employer, right? Again, these are all possible risks. Somebody that fidgets in their seat a lot or moves around frequently doesn't mean they're being trafficked, right? But if that in combination with somebody who is living at work and it identifies as being very hungry all the time, that might be an indicator that they're experiencing some type of harm, potentially trafficking. When they're looking at labor or sex trafficking or both, right? Are they experiencing any of those things that are happening to them? You see signs, ask your coworker trained in using the screening tool, right? You don't have to be the one doing the screening tool, but somebody should be screening something, right? And if your agency doesn't have a screening tool like this, maybe implement one, bring it to their attention. See if something does exist and you just don't know about it yet. All right, so a screening flow chart for adults at risk of human trafficking. This chart can help guide the development of internal protocols for responding to human trafficking. Key points, red flags list, which we just talked about, the screening tool found in the workbook for adults. And again, this is not an exhaustive list. Screening may vary per patient, and not all experiences of human trafficking may flag, right? Not everything is going to be as cut and dry as a screening tool says it is. And somebody who's being trafficked might not disclose any of this either, and they might still very well be experiencing it. So review the red flags list. Are there any? If yes, use the screening tool. Okay. Did somebody accompany them? Yeah. Yep. Agency says that only patients are allowed in this area. I'm sorry, I have to ask you to step out. Staying away, or stay aware of this person's location. Are they standing over them? Are they standing over your shoulder? How are they interacting with you, right? If there is nobody accompanying them, is an interpreter needed? If so, arrange for a certified interpreter, and begin the screening process in a private area. Again, asking them to leave if there is somebody else in there. Establish rapport, right? Explain that the screening is a standard, but also don't just say like, I'm sorry, I have to do this. It's required by my agency. Say, hi, I have a few questions to ask you. And while my office does require this, I really care about your response. And I want you to feel like this is a safe place to answer these honestly. How different does that sound? Engaging, rapport building, and getting them to feel safe to open up and ask questions conversationally. It's not just a checkbox like, do you have this? Do you have this? Do you have this? Create a conversation out of it. Have dialogue. It might take an extra minute, but that extra minute could save somebody's life. And do they answer yes to any of the questions on the screening tool? If they do, safety plan. If you don't know what a safety plan is, we'll talk about it later. But you want to connect them to other resources, and do so in a way that isn't like, you need this, but like, here's some options in the community if you feel like they could benefit you. If not, that's okay. We can talk about something else too, right? And if they answered no, again, offer resources. Maybe somebody they know is experiencing something unhealthy and they want to be able to help them, right? It's never a bad thing to offer more resources than necessary. So when we look at evidence-informed assessment of risk at the individual level, we, referring patients who present with those risk factors to the appropriate personnel for assessment, maybe their primary provider or an assigned clinician, or if you're able to do it yourself, right? And provide those comprehensive resources. For those who, maybe you have somebody in your agency who is specifically assigned and trained to address trafficking. Awesome. Educate the patient on confidentiality, privacy, mandated reporting. What does that look like before you conduct an assessment? And empower patient autonomy to share only what they feel safe in sharing. Because if they say, I'm sorry, I don't feel safe answering that, or I'm not comfortable answering that question right now, might be an indicator that something bad is happening, right? Might not be, but it might be. And again, use those evidence-based or evidence-informed tools to address the risk of trafficking. At an organizational or institutional level, create a setting for patients that supports confidentiality and is trauma-informed, culturally and linguistically appropriate. So again, like the screening tool said earlier, I'm sorry, it's agency policy that just the patient being here right now. I know you care about them, but can we have you wait in the waiting area until we finish this screening, right? That maybe your agency doesn't have that policy in place, and that's something that you can bring to the table. Determine and train appropriate personnel on conducting these assessments when indicators have been recognized, and training people on indicators. Do you know what the indicators are? Do the other folks in your office know what those indicators are? If not, how are you going to do an assessment, right? You need to understand these in order to properly provide comprehensive services to folks who've experienced trafficking. And establish a systems-wide policy to see patients alone, right? Again, not in place. See if you can get it in place. Research, evaluate those existing tools and identify individuals who've experienced trafficking. Again, are they 20 years old, 5 years old, 2 years old? What does that look like? Develop and use existing tools that are up to date, trauma-informed, victim-centered, and solicit feedback from experts with lived experience about the effectiveness of approaching screening tools and early intervention. If people who have experienced human trafficking say the screening tool did nothing, or it made them more fearful, or it prevented them from disclosing, maybe that's not the best thing to do. See if there's people in your community, in your service area, people who've received services from you, if the screening tool was helpful. Education, again, evidence-based, specialized, trauma-informed, patient-centered, and client-centered trainings for conducting assessments. Competency 3. So evaluating the needs of individuals who have experienced trafficking or individuals who are at risk of trafficking, broken down into 3 categories: a needs assessment, a plan of action, and practice within the scope and your community referrals. Healthcare professionals should engage in with the patient in shared decision-making processes that are developmentally appropriate, empowering the patient to make decisions about their treatment, their safety, and what referrals are best to them. And I want to focus on that developmentally appropriate piece, right? If there is a developmental delay, if you're talking with a child, or if you're talking with somebody elderly, what does that look like? What language are you using? Who else is in the room? What needs do they have beyond the suspicion of possibly being exploited that you can incorporate into their care? Healthcare professionals should remain within the scope of their practice in providing care, while also being knowledgeable about other internal and community and external supportive services. Taking a multidisciplinary approach can and will allow for comprehensive wraparound services when and if disclosures happen, right? If you are the only care provider for this person, they are not getting the services that they need, right? We cannot all do all of these jobs as one person. It is not, it does not deter your work or degrade it in any way by acknowledging that you are not the person able to provide that service, right? It means that you are humble and you're willing to acknowledge that you are not the best person for that. I do it, you can do it too. So a needs assessment, individual. So understanding the common and varied needs of individuals who have experienced trafficking, individuals who are at risk of trafficking, and their families, right? We talked earlier about secondary victimization, and I didn't go into too much detail about that for a reason, because families are considered secondary victims, at least in the services we provide, right? They are somebody who might not have experienced the trafficking or the exploitation or the harms themselves, but somebody they love did. That's still impactful. It still affects them, and they are entitled to services as well. So if somebody in your care discloses that their child, was recently taken advantage of by an older adult, and they don't know how to do it, and it's causing significant stress, maybe making hair loss or weight loss or things like that, that impacts them and their health. And it's appropriate to refer them to the same victim resources as you would their child or somebody else that they care about. Conduct individualized needs assessments with all patients or identified as having experienced trafficking or individuals that are at the risk of trafficking, right? Every care should be individualized, specific to that person, their needs, right? Everyone is unique in their own way, and they come with their own experiences that they are the expert of. Conduct safety planning with all patients or clients identified as individuals who are at risk of trafficking, and consider the context, including the potential familial abusers of trafficking, right? So safety plan, talking about people that they feel comfortable talking to or calling or relying on in a time of need, or finding a safe place for them to go to if they're not able to leave their home. Is there a room that they can be in that they feel safe? Rooms that they can avoid, maybe, right? Maybe not the kitchen or the bathroom because there's hard surfaces and sharp objects, but maybe their bedroom, or maybe the living room, or in a closet somewhere, right? Whatever feels safe for them, helping them identify who the people are in their life that they can rely on that are safe to them, what spaces make them feel safe and comfortable and secure, and then what other resources are available to them and things that they have access to. Maybe always having their cell phone on them, or having a backup cell phone stashed somewhere in the home, or having their speed dial set up, or a code word that they can share, right? All of those different things are elements that can be put into a safety plan to help people if they're stuck in an unsafe situation. Looking at organization and institution. Oh, yes, Josie.
Yeah, so I had a quick question. In the previous slide, you mentioned about if you are not able to provide a person the resources that they need, and you build that rapport with them. And what are you supposed to do in situations where they only want to confide with you because of that trust, and they don't feel comfortable opening up with others? What are we supposed to do in those situations?
Yeah, that's a really good question. And it's really about talking to the patient about why they don't feel comfortable opening up to somebody else. If you're a clinician, if you're their primary care doctor and they confide in you, you can say I'm so grateful that you feel safe talking to me, and I want you to know that you can continue to talk to me, but here are other safe people that I can refer you to. And if you would be more comfortable with, if you have the ability to, right? I know that not everybody has the privilege of this time or ability, but saying we can maybe set up a call together and I can be a part of that referral process with you. Or, if I get a release of information, I can share with them what you have shared with me already, so you don't have to redisclose. And then they can help you through this process. Or, asking them, what are some barriers for you that are making you fearful of sharing this story with somebody else? Is it because you feel like you won't be believed? Is it because, I'm the first person to have acknowledged your harm? What does that look like? So I would say the biggest thing in cases like that, where somebody is reluctant to work with other survivors or work with other providers, is to identify where those barriers and reluctancies are coming from, and then offer options to help streamline that process, because that happens a lot. There's a lot of people that I've worked with that are like, I don't want to work with anybody else. Okay, I understand that, but you are not going to get the care that you need and the resources that are going to be best for you by just talking to me. And I care about your well-being and outcome enough to know that I am not capable of giving you everything that you need right now. And sometimes that can be really, really helpful for survivors. Yeah, and Amanda dropped in the chat here too, especially if you're able to give specific information about the victim service provider to whomever you're referring. So their name, the fact that they've successfully referred other patients, that somebody I really trust for the following reasons, right? Those are all huge things to be able to help them feel trustworthy in working with somebody in addition to you. Yeah, really good question. Okay, so let's see. I think I covered all of the individual here. Moving on to the organization and institution piece. So training and supervising relevant personnel to conduct individual needs assessments for patients identified as or have experienced or at risk of trafficking. And then creating protocols for crisis intervention in emergency situations following a disclosure or identifiable risk. And that can include mental health crises, risk associated with potential traffickers interfering in the healthcare system. What happens if somebody is in crisis and you have to refer them somewhere, or they maybe need to go to the behavioral health unit of your clinic versus the emergency department, or they might be at risk for harming themselves or somebody else? What does that look like for you? And is that different when responding to survivors of trafficking versus responding to other patients with different lived experiences? Looking at research, so identifying short and long-term healthcare needs that are most prevalent among individuals with risk of trafficking, experiencing trafficking, or their family members. So what has research shown in your area to be those short and long-term risks? Is it referrals to AODA inpatient treatment facilities or detox centers? And AODA meaning alcohol and other drug addiction, or alcohol and other drug use facilities. Is it providing behavioral health needs for substantial mental health concerns? Is it referring to advocacy agencies because they are unable to differentiate between their what love and what they have been groomed to believe is love, right? What does that look like, and what are those needs, short and long term, that are impacting individuals at risk or the experience of trafficking? You want to develop, validate, and rigorously evaluate those needs, assessment tools specific to individuals who are experiencing trafficking, right? If they're not working in your agency, maybe switch it out for a different one, or maybe adapt it to one that is specific to your role, right? You work in an AODA facility, right? Maybe you need to change the screening tool because yours needs to be specific to substance use, right? What does that look like for your specific place of work and how you are working with survivors? And again, evaluate and modify tools for use within varied populations. Does your tool predominantly focus on white women? Or does your tool also allow for people who identify as being Black, brown, male, gender non-binary or non-conforming, right? What does that look like? What is the language on the tool? Does it only say he or her? Does it allow for they and them, right? What does that look like? And then education. Incorporating case studies into your healthcare trainings, which encourage individualized needs assessments and navigation of those varied health and behavioral health needs, among others, that of the individuals with lived experience. So again, those case studies, whether it's on MDTs, CCRs, or within an internal protocol that you have, bringing in real examples or even examples that are based in reality, right? It might not be a real person, but it's experiences that you have heard or that are real, but might not be associated with a specific person in your care. And develop and conduct training simulations, again, role play, go through the needs assessments with one of your colleagues, have them pretend to, be in the role of a trafficking survivor and go through that experience of doing a screener. How did it feel to be asked those questions, to have your privacy invaded in that way, to feel like somebody sees you as somebody in need of help, right? How does it feel to do that? So you can take those feelings into the care you provide long-term. B, a plan of action. So I will start on I realize this is kind of laid out a little funky. But so individual, creating a plan of action with patients who have those specific needs that are considerate of their age, their developmental level, cultural and linguistic context, what their citizenship is, their family, and ACEs and social determinants of health, right? What does that plan look like for their care long-term? And how does it incorporate the risk factors, the vulnerabilities they may have by other providers, even within the same clinic? Apply a strength-based approach in planning with the patient. So what are their strengths? Focuses on the things that they're good at, things that are empowering them, things that are going to set them up for success. And again, that resiliency, focusing on what they are resilient to, not the things that have happened to them. Going back to the video we watched at the beginning, right? It's not about what happened to you. It is about what has been, like, what did you do to put yourself in the situation? It's about what has been done to you and what are you doing to survive that, and how can we change it so you no longer have to be in survival mode. Then use shared decision-making processes to empower the patient to express their needs and preferences. Again, developmentally appropriate. If you're working with somebody who is 10 years old compared to somebody who is 55 years old, those conversations are going to be different. Organization and institution, integrating organizational protocols that clearly articulate the responsibilities of different staff and how they respond to individuals that present with risk factors, right? Somebody might disclose in a, in a primary care appointment, and then in the next appointment, they might not share anything else, right? What does that look like? Create policies and procedures that ease access and lower barriers to those that identify as having been trafficked or at risk of being trafficked. And what that looks like for in-network medical and behavioral health referrals. What are the resources that you were able to refer them to streamlined without barriers? Ensure that there is a dynamic directory of service providers, especially those with your local, regional, and national resources that is maintained and accessible to healthcare providers. Do you know the resources in your area? Do you know, culturally specific resources, LGBTQ specific resources, environmental specific resources. Are they all in your network, in your area locally? If not, what's in the region? If not there, what's in the state, right? What options are available to these survivors that you can refer them to easily and accessibly? And conduct patient-client service coordination within your institution and wherever possible through multidisciplinary teams. Have a relationship with those in your community. Have those conversations. Reach out. Set up meet and greets. That's one of my favorite things to do, is to just sit down with people in my community and understand what they do so I can refer people there or they can refer people here, right? Having that rapport built among providers can easily streamline those referral processes for survivors within your community. And looking at research, so expanding research in partnership with those with lived experience expertise on the needs of individuals that have experienced trafficking, the effectiveness of trauma-informed approaches, and shared decision-making among individuals with trafficking and those that are among those multidisciplinary teams that provide that comprehensive case management service and access to additional resources. And educate healthcare providers on safety planning, how to do it, what it looks like, what the shared decision-making process piece is, and multidisciplinary collaboration, and how to reach out to those community members that have expertise and lived experience, or both. And C, the practice and with scope and community. Oh my goodness, practice with the scope and community referrals. So individual, again, understand and remain within your scope of practice, within your licensure. What can and can you not do? And how do you communicate to folks that you're unable to do that? Recently, I had to terminate a participant of mine because I was unable to provide them with the services they needed. And the way I went about that, through guidance of those that I am able to confide in and have those conversations with, was to talk about my ethical obligation to ensure that they had access to the services that were going to best fit their needs. And I was not one of those. I was not one of those people anymore. I don't want to cause more harm to them than good. And that's when you have to draw that line, and you have to know what that line is. Determine those appropriate cultural responsive referrals, and in collaboration with the patient. So you don't have to just like hand off somebody. You can work alongside somebody else. If I'm working with a participant and they have a culturally specific need that I cannot meet, doesn't mean I can no longer work with them. It means I can bring somebody else in that meets that need and is then able to collaborate with me and the participant on meeting the need that they have, so we can continue to work on the other needs that I am able to meet with them. Organization and institution. So train and supervise relevant personnel on conducting these needs assessments and identifying individuals who have experienced or risks for trafficking. Create protocol for crisis intervention. So some of these are kind of overlapping as the others, right? But what is your protocol for crisis intervention? You don't have one? You should probably create one. And that includes individual mental health crises, risks associated with those. Is the trafficker involved? Are they in the clinic? What does that look like, and how can you have those conversations? And what other personnel in your building is able to come in and assist with that, so it's not just you? In research, identify short and long-term healthcare needs most prevalent among individuals who are at risk of trafficking. Individuals who had experience with trafficking and those and their families specifically. So again, what are the short and long-term needs that can be reached by you, but then by others in your community? What does that look like? And then develop, validate, and evaluate needs assessment tools. Again, a lot of this is repeated from the last slide and what that looks like. And then incorporate case studies, again, very similar to the last slide, but that navigate those behavioral and health needs and conduct those simulations, those role play situations on the scope and community referrals. Any questions on the first three competencies that we have discussed so far? All right, well, then we will break for lunch. We can come back at, let's see, I'll just give you all until 12:30. So we'll have about an hour. So we're running a little ahead of schedule, which is great. So we can reconvene at 12:30.